Let's dive right into this explainer. Today, we're exploring a fascinating but honestly incredibly challenging area of pediatric medicine, which is what happens when a child's own immune system becomes the invader. We're going to look at the immune system not as a defender, but as a confused aggressor, and see exactly how this battle plays out in two very different childhood conditions.
So what actually happens when a kid's body turns against itself? To really understand pediatric rheumatology, we need to contrast two distinct autoimmune battles, focusing heavily on how they present and how we as healthcare providers have to prioritize care. Because when the body attacks itself, the resulting damage depends entirely on the chosen battlefield. Is the immune system targeting the hinges that allow a child to run and play? Or is it launching a stealth attack on vital internal organs?
Here's our roadmap for today. We'll start with childhood autoimmune battles in general, then dive deep into JIA's joint-centered issues and its specific medication ladder. After that, we'll shift gears to SLE, which is a whole different beast, a multi-system disease, and finally we'll put them head-to-head in a JIA versus SLE showdown.
Let's kick things off with Section 1, Childhood Autoimmune Battles. First up is Juvenile Idiopathic Arthritis, or JIA. This is driven by an abnormal immune response that causes chronic inflammation of the synovium. That's the protective lining of the joint. When it gets inflamed, it progressively wears down the cartilage underneath. Now, while it's rarely life-threatening, if you leave it unchecked, it can result in permanent joint deformities. We're talking about completely altering the function and mobility of a growing, active child who really just wants to run around and play.
Moving right along to Section 2, JIA's joint-centered manifestations.
As the name implies, the classic manifestations here are highly joint-centered. You're very often going to see a child with a noticeable limp, or they'll have significant stiffness that is notably worse in the morning or after they've been sitting still for a long period of time. And because this intense inflammation is happening right where the bones are actively growing, JIA can actually lead to delayed overall growth or even crazy things like limb length differences. It directly impacts their fundamental development.
Now, this brings us to an absolute must-know red flag. JIA carries a massive risk for silent uveitis. Uveitis is inflammation inside the eye, and it is a huge threat to a child's vision. If a child has a positive ANA lab result, their risk shoots up even more. But here is the critical part you absolutely have to remember. This condition is often completely silent. Routine slit-lamp eye exams by an ophthalmologist are mandatory even if the child has zero eye complaints to prevent irreversible blindness. You literally cannot wait for them to tell you their eyes hurt.
Let's look at how we manage this in Section 3, JIA medication and care.
Think of the JIA treatment strategy as a highly structured medication ladder. We always start with NSAIDs as our first line to manage the pain and knock down that baseline inflammation. But if NSAIDs just aren't enough to stop the actual physical destruction of the joint, we have to step up to methotrexate, which is a disease-modifying drug. Finally, if those fail, we reserve the heavy hitters, biologics like etanercept or infliximab, for when we really need to control severe disease activity.
Okay, pay super close attention here because this is a massive safety alert for your clinical practice. Methotrexate is a potent, teratogenic, disease-modifying medication. It must be administered weekly, not daily. I repeat, weekly. A mix-up here can be incredibly dangerous for the patient. Because of its sheer potency, it requires strict, ongoing monitoring of liver function tests and complete blood counts just to make sure we're catching any bone marrow suppression or liver toxicity early.
Now, if a child's disease is severe enough that they step up to those biologic agents like etanercept or infliximab, your priority as a provider shifts dramatically. These drugs work by suppressing the immune system to decrease inflammation. That means strict infection risk monitoring becomes your top priority. A tuberculin skin test is required prior to starting these meds and yearly after that. You also have to aggressively educate the family to avoid infectious exposures and keep a close eye out for signs of lymphoma.
When it comes to the highest yield nursing interventions for JIA, the stuff you'll use constantly, it really comes down to two things. First, administering those NSAIDs, always with food, to prevent gastric irritation. And second, applying morning warmth. Having the child take a warm bath or using warm, moist packs in the morning are incredible, non-pharmacologic ways to melt away that debilitating morning joint stiffness and help them get moving for the day.
Let's pivot to our second condition in Section 4, SLE, the multi-system disease.
Systemic lupus erythematosus, or SLE, is totally different. It's a shapeshifter. It's a multi-system disease that hops from organ to organ.
Yes, it can cause joint pain, but it famously presents with a mauler, or butterfly rash, right across the bridge of the nose and cheeks. But the real danger with SLE lies beneath the surface. It launches insidious attacks on the blood, causing anemia, and can have severe, life-threatening impacts on major internal organs.
Because it's a multi-system invader, your nursing priorities for a child with SLE immediately shift to monitoring the kidneys and the neurologic system. Why? Because organ involvement is the absolute highest priority complication. You are watching intensely for things like decreased urine output, protein or blood in the urine, severe headaches or seizures. This is where SLE goes from a chronic nuisance to an incredibly dangerous situation.
It's also crucial to note a major difference in how we approach treatment. SLE actually has much less structured medication monitoring detail available in the standard pediatric literature compared to JIA. Its management is highly individualized based on exactly which organ is currently under attack. So never falsely project that rigid JIA step-up ladder onto an SLE patient. You have to treat the specific organ that's involved at that moment.
All right, let's bring it all together for Section 5, the JIA versus SLE showdown.
This lays out the two battle plans perfectly side by side. JIA is all about protecting those joints with morning warmth and range of motion exercises and fiercely protecting the eyes from silent uveitis using strict medication ladders and slit lamp exams. SLE, on the other hand, is about defending major organs from a massive multi-system attack. We're prioritizing flare prevention, getting plenty of rest, and maintaining hypervigilant renal and neurologic monitoring.
Clinically, your brain has to go down two totally different pathways depending on which disease you're looking at. A routine JIA presentation means managing mobility, relieving stiffness, and making absolutely sure ophthalmology follow-up happens. But an SLE escalation, we're talking about decreased urine output or altered mental status. That requires dropping everything for urgent organ evaluation and systemic support to prevent life-threatening organ failure.
I'll leave you with this to chew on for your own clinical practice. Autoimmune diseases in children are masters of disguise. When a kid walks into the clinic with joint stiffness, based on their exact symptoms and what you know about the distinct battle plans of JIA versus SLE, will you know instinctively whether to check their eyes to prevent blindness or check their kidneys to prevent organ failure? Keep that question in the back of your mind as you step out onto the floor.